Medicare is changing how physicians are paid, and this change begins with services provided in 2017. The American Academy of Ophthalmology leadership, staff, and member volunteers are striving to ensure that this massive and complex change works for our community of U.S. ophthalmologists. To help you succeed, we've created this video, Value over Volume. It's an overview for ophthalmologists of this transformative new payment system. The Academy's website, aao.org, also provides detailed guidance on the best way to participate in Medicare. This video describes the Quality Payment Program, Medicare's new physician reimbursement system. In the video, we'll tell you how Medicare intends to shift today's value-driven payment system into one that places a premium on the value of care.
To understand where we are, let's talk about where we were. The root of this change is in the Medicare Access and CHIP Reauthorization Act of 2015. Some of you might know this law as MACRA. Congress passed MACRA as part of a larger effort to repeal the flawed Sustainable Growth Rate formula. It passed with strong bipartisan support, and President Obama signed it into law in April 2015. In addition to repealing the Sustainable Growth Rate formula, the law instructed the Centers for Medicare and Medicaid Services to change how physicians are reimbursed for seeing Medicare patients. The system is intended to reward physicians who provide high-value care. Overall, the new system will streamline current programs and reduce the potential penalty burden. It also provides opportunities for those specialties with a clinical data registry, like IRIS. CMS is calling the new payment system the Quality Payment Program. This is the new system established under the Medicare Access and CHIP Reauthorization Act. For this program, eligible providers can choose to participate in one of two ways. One choice is a fee-for-service option. It's called the Merit-Based Incentive Payment System, or MIPS. It combines existing quality reporting and resource use programs with some new elements. The other participation option is in an alternative payment model, or APM. APMs incentivize quality and value using a new approach to paying providers who treat Medicare patients. The timeline for implementing the Quality Payment Program began in spring 2016, when CMS first unveiled its proposal. We received the final configuration from the agency in October, which reflected the input of the Academy and many others across medicine. We're now focusing on preparing our members on the transition to the Quality Payment Program, and in particular, the Merit-Based Incentive Payment System. You should start preparing for this transition now, because time is of the essence. Physician performance in 2017 will directly impact reimbursements in 2019. Let's focus on the two options for the participation under the Quality Payment Program. Alternative payment models are voluntary models. They change the way that CMS pays physicians. Some examples of APMs may include accountable care organizations, patient-centered medical homes, and bundled payment models. Under the new program, physicians can elect to participate in an advanced APM. This would be instead of the merit-based incentive payment system. Providers who successfully participate in an advanced APM would be exempt from MIPS and would qualify for bonus payments. However, CMS proposed very strict criteria for what models qualify as advanced APMs. Because of this, there are very few models that currently exist. Most ophthalmologists would not be eligible to participate in any of the existing models. MIPS is the fee-for-service option. It is also the likeliest path for the majority of ophthalmologists. MIPS is a consolidation of existing federal reporting programs. It has some new elements. Its overall intent is to tie payment to quality and overall costs of care. Under the Quality Payment Program, all physicians will receive a 0.5% update to the annual conversion factor from 2016 through 2019. No update is guaranteed between 2020 and 2025. During that time, physician updates will be based on performance in their track, whether it's the merit-based incentive payment system or an advanced alternative payment model. Based on your 2017 performance, the maximum 2019 payment adjustment under MIPS is 4%. In 2020, this increases to 5%, 7% in 2021, and 9% in 2022. After that, it will be capped at 9%. Providers who do not participate at all in MIPS or an advanced APM will earn an automatic penalty. However, consider this. Under existing programs, physicians are expecting penalties as high as 11% by 2018. That means the MIPS payment adjustments are actually an improvement. MIPS is a budget-neutral program. This means that penalty dollars are pooled together and used to pay physician bonuses. So if there is a substantial pool of penalties, the program allows for the positive adjustment to be scaled up to 3 times. This means the maximum bonus amount could be tripled. In addition, the Medicare Access and CHIP Reauthorization Act provided $500 million that will be awarded to providers who achieve exceptional performance under MIPS between the years 2019 and 2024. As we mentioned, the merit-based incentive payment system is the most likely pathway for the majority of ophthalmologists. Based on performance in 2017, it impacts payments beginning on January 1, 2019. MIPS consolidates and replaces several existing incentive programs. These programs include the Physician Quality Reporting System known as PQRS. It also includes the Electronic Health Record Incentive Programs, formerly known as Meaningful Use, and rebranded under MIPS as Advancing Care Information. Finally, the Value-Based Modifier Program. Providers will receive a score based on how they perform under MIPS. Their score then dictates their payment adjustment. The Academy and many other medical groups expressed a great deal of trepidation over the transition to this new program. Consequently, CMS says it is offering timing flexibility in the program's first few years, especially in 2017. This is meant to help providers during this transition to the quality payment program. CMS calls this program Pick Your Pace, and it is very clearly designed to help physicians easily avoid penalties during the quality payment program's first year. In some cases, physicians can qualify for bonuses with a minimal amount of reporting. This increased flexibility lets physicians completely avoid a penalty for 2019 by reporting on a single measure or clinical practice improvement activity. Physicians who want to earn a bonus can qualify by reporting on a 90-day period at any point in 2017. We welcome this effort by CMS to offer flexibility. We're also encouraged by the agency's suggestion that it will consider 2018 as another transition year. Still, we have a number of questions as to how future flexibility will look. We'll work with CMS to ensure that its future policies meet the intent of this flexibility. While what we're discussing today relates to the final configuration of the policy that CMS unveiled in October 2016, our work continues. We're looking forward to seeing this new system in action and will continue working with the federal government to ensure that if changes are made, that they're the right changes for our profession. CMS proposed that if you see fewer than 100 Medicare patients or bill less than $30,000 in Medicare charges, you are not required to participate in the merit-based incentive payment system. You're excluded from MIPS penalties. Other excluded providers include physicians who newly enroll in Medicare during the reporting year. Those who successfully participate in an advanced alternative payment model are also excluded. Physicians who are not excluded from MIPS must participate in some way to avoid negative payment adjustments. Most eye care professionals will not qualify for an exclusion from MIPS or for an APM, in part because of the demographics of our core base of patients. MIPS is therefore the pathway that will be taken by the vast majority of ophthalmologists and optometrists. The merit-based incentive payment system measures physician performance in 4 categories. The first is quality. It replaces the PQRS program. The second is advancing care information. This replaces the meaningful use program. Third, an all-new category, clinical practice improvement activities. Finally, MIPS measures resource use. This replaces the value-based modifier program. Each category is assigned a weight. Together, they equal your total score from 0 to 100, which is being called the composite performance score. Your score will determine any payment adjustments. Today, under the payment system that's going away, there are 3 separate incentive programs. Each has its own separate reporting requirements and structures. Penalties for 2018 from these programs will reach as high as 11%. There are also no more bonus payments under PQRS or meaningful use. The merit-based incentive payment system changes that. It aims to streamline these 3 programs into one. Penalties will fall from 11% in 2018 to 4% in 2019. Under MIPS, successful participants have the ability to earn bonus payments. The quality category under the merit-based incentive payment system is similar to PQRS. However, there are some key proposed changes. For example, rather than requiring providers to report on 9 quality measures, CMS has proposed that MIPS participants report on just 6. At least one of these measures must be a cross-cutting measure. One must be a patient outcome measure. But unlike PQRS, the Centers for Medicare and Medicaid Services is proposing to award partial credit. Under MIPS, physicians will be credited even if they report on fewer than 6 measures or do not report on a cross-cutting or patient outcome measure. There are some changes proposed by CMS in the quality category that the Academy opposes. For example, CMS is suggesting the elimination of measures groups. These include measures groups for cataracts and diabetic retinopathy. CMS also proposed a significant increase in the patient reporting requirement bar. Claims reporters would have to report on 80% of their Medicare patients. That's up from today's 50% requirement. It would also require EHR, qualified registry, and qualified clinical data registry reporters to report on 90% of patients from all payers, rather than today's 50% for registry reporting. Under the merit-based incentive payment system, meaningful use will be renamed Advancing Care Information. In 2017, providers will continue to report on the Meaningful Use Program's modified Stage 2 measures. CMS proposed requiring all providers to report the more difficult Stage 3 measure in 2018. Under Advancing Care Information, CMS plans to eliminate the arbitrary patient reporting thresholds that require physicians to perform a specific action, e-prescribing, for example, on a set percent of their patients. Instead, in order to meet the minimum reporting requirement, physicians must report each measure for only a single patient, or they might need to fulfill required actions for all of the yes-no measures. CMS proposed allowing practices who wish to participate in MIPS at the group level the option to report advancing care information as a group. This is a departure from the current requirement, for which all participants report as individuals. It also proposed to do away with the computerized provider order entry measure. This would eliminate the need to have scribes certified. Let's talk about the new Clinical Practice Improvement Activity category. For this category, CMS plans to require providers to choose from a list of activities that they will complete. These are all aimed at improving clinical practice. Each activity will be assigned a point value to count towards CMS's proposed goal of 60 points. You'll get partial credit if you fall short of that total. Small practices gain some relief in this category. CMS proposed that practices with 15 or fewer providers can earn the full score by reporting on 2 activities, regardless of their point value. CMS outlined a list of 90 activities that will count as a clinical practice improvement activity. Some of these include participating in a registry, such as the Academy's IRIS registry. Other options include offering expanded office hours and offering same or next-day urgent care when needed. The resource use category is intended to evaluate physicians based on their costs and resources used when treating their patients. For this merit-based incentive payment system category, no reporting by the physician is required. Instead, CMS will calculate a provider's resource use score completely from administrative claims. Physicians are evaluated on 2 measures that are carried over from the value-based modifier. These are total per capita cost and Medicare spending per beneficiary. In addition to those measures, CMS proposed using a number of new episode-based groups to determine resource use comparisons. These include one for lens and cataract episodes. Additional ophthalmology episodes are under consideration by CMS. The Academy believes that the resource use category is inherently flawed. It has a number of major problems, including inappropriate attribution of costs to providers who have no control over care provided by other physicians or facilities. Another issue is that the variation based on a physician's subspecialty is not taken into consideration. The measures also have insufficient risk adjustment to account for patients and other factors. Your 2017 performance score will determine your payment adjustments in 2019. Now is the time to get started in preparing for the transition. CMS estimates that the majority of physicians across all specialties will be in the merit-based incentive payment system. The Academy encourages all ophthalmologists to start getting ready for a 2017 implementation. As we mentioned, there is a second track to the new payment system: alternative payment models. This will not be the track for the vast majority of ophthalmologists. Only providers who successfully participate in an advanced alternative payment model will be exempt from the merit-based incentive payment system. However, at the onset of the quality payment program, there are only a few CMS proposed models that qualify as an advanced APM. This is because these models require 2-sided financial risk. In addition, advanced APM participants must receive enough of their payments or see enough of their patients through the APM model. These thresholds are a significant barrier for the advanced APM pathway. The Academy believes that thresholds established by CMS are too high for most physicians to achieve. Successful advanced APM participants are excluded from payment adjustments under MIPS. Instead, these providers will receive a 5% bonus from 2019 to 2024. The Academy is here to help our members with the transition. The Academy worked for months to ensure that this policy is right for ophthalmologists. When CMS unveiled its final configuration, it included many elements we pushed for during 2016. These include added flexibility through the Pick Your Pace program. We also gained expanded exemptions, changes to the cost category, and an easing of the clinical practice improvement requirements. We also secured more flexibility through shorter reporting periods. The Advancing Care Information category has fewer requirements, and the burdens for quality reporting have been lessened. Using the Academy's IRIS registry to participate in the merit-based incentive payment system will provide a number of benefits. The IRIS registry will help participants to meet the quality reporting requirements and will offer a number of patient outcome measures from which participants may choose. For the quality category, CMS proposes to allow physicians to earn bonus points when they report on multiple outcome measures. The same holds when they report quality measures electronically. IRIS registry participants will also be well positioned to earn bonus points and maximize their quality performance under MIPS. In addition, Participating in the IRIS registry will allow physicians to get credit for several proposed clinical practice improvement activities. The IRIS registry will also support reporting for the Advancing Care Information category. Your Academy recommends that all members take steps to prepare for the merit-based incentive payment system. We will continue to develop resources and provide information as it is released from CMS. We're dedicated to helping you succeed in this new program. Start by visiting aao.org/Medicare. This is where you'll find the latest information on the Quality Payment Program and the Merit-Based Incentive Payment System. We also encourage you to submit your MIPS-related questions to Academy experts at healthpolicy@aao.org.
While the CMS goal of emphasizing value of care is logical and appropriate, there's no question that, like all new programs, the merit-based incentive payment system will be a frustrating work in progress for years to come. It's equally clear that commercial insurance payers will follow and at times lead the CMS payment changes. So the principles and processes embedded in these changes will affect the entire payer community. The Academy is hard at work to prepare you for this transition. This includes our extensive efforts in Washington, D.C. We're working to secure changes to improve the merit-based incentive payment system and to ensure that all ophthalmologists have a chance to succeed. Our goal is to make this program work for our profession. The first step is trying to assist every American ophthalmologist understand this complex process, and we hope this video has helped. Please don't hesitate to contact the Academy at healthpolicy@aao.org with questions or problems. Thank you.